Let's talk about induction of general anesthesia. Induction, meaning that we're transitioning from a state of wakefulness to a state of unconsciousness, which is general anesthesia. Now, in the US, we have 3 sedative agents that we use for induction of general anesthesia. First one is propofol, second one is ketamine, third one is etomidate. The most go-to one that we use in the operating room is propofol. The other 2 are used a lot less than propofol. How do they work? So propofol and etomidate both work very similarly. They both are working at the GABA receptor, which is GABA aminobutyric acid. That is the inhibitory neurotransmitter of the neurons, of the CNS system, the central nervous system. So that system basically works the opposite of excitation. So if you are working on those receptors, you are going to cause a state of relaxation of the brain. And if you give enough medication, obviously you're going to render the person unconscious. Ketamine is slightly different in that it works against the NMDA receptors. Now, the NMDA receptors are receptors of glutamate. Glutamate is the excitatory neurotransmitter of the brain. So if you are going to inhibit glutamate by working against the NMDA receptor, you're going to, in essence, do the same thing as propofol and etomidate. But it's slightly different in that ketamine can cause a state of awake dissociation because of the receptor that it tends to work on. The biggest issue that we have with propofol is it can drop somebody's blood pressure. Typically, in a young person, this is not too much of a big deal because we have compensatory mechanism and the patient's body is usually able to tolerate it if they are young and healthy. Compensatory mechanisms meaning the increase in the heart rate in order to increase your cardiac output. Now, we start to worry about this when the patient tends to be older or has other cardiac, typically comorbidities. If that patient's blood pressure drops significantly, then you're worried about potentially not having enough oxygen be supplied to the myocardium because the blood pressure is too low. So that's one of the biggest things that we do have to worry about in some sicker patients who cannot tolerate the level of hypotension that goes along with propofol. Now, etomidate tends to be a lot more cardio stable, but as an ICU physician myself, I have seen patients go down with etomidate as well. It really depends on the patient, but it's more cardio stable than propofol. And ketamine is one they say that tends to be the most cardio stable. But again, in a select few patients, you can have the same type of hypotension that I talked about with the previous 2. So we can talk about specifics of propofol and etomidate and ketamine in future videos. And we can also talk about inducing general anesthesia in pediatric patients with inhalational agents, which in the US are sevoflurane, isoflurane, which I have not seen in many hospitals in a very long time, and desflurane, which is not good for inducing because it causes a lot of airway irritability. So in induction with inhalational agent, we use typically sevoflurane.